I think we are live. So, a very good evening to everyone who's joining in here. So, I'm Dr. Sandeep Sharma. I'm the pediatric faculty at DocTutorials. And this is a session where I'm going to discuss a very, very important case scenario and the differential diagnosis, that is Kawasaki disease and its mimics. If you are thinking that I am going to teach you Kawasaki disease, no, this is not what this session is. Because when tomorrow you will be sitting in your OPD and you will be seeing patients, patient will not come to you and say कि I have Kawasaki disease. Patient will be presenting with a group of features. Sometimes the diagnosis will be Kawasaki disease. Sometimes it will not be Kawasaki. It will be a differential diagnosis like scarlet fever, like adenoviral infection, or other similar mimics. How to clinically distinguish between them? What does Nelson talk about? And how do the patients actually present? This is what I'm going to discuss. In short, it is a actual similar case scenario to real life that I'm going to discuss with you. And I will be highlighting a few points which are important as a resident for you to understand, some of the points which are mentioned in Nelson. So that is going to be useful for your competitive exam as well. But let us go and delve into the world of Kawasaki disease and its mimics. First of all, let us have a look at the case scenario. So the case scenario will be something like this. The patient will be presenting to you. It will be a young child. There is a 4-year-old boy, a resident of Chandigarh, who was brought to OPD with complaints of high grade fever for past 1 week. High grade fever for past 1 week could be anything. It could be an infection, it could be an inflammation, or it could be a drug reaction kind of thing. Okay, so high grade fever for past 1 week is the chief complaint. There were no upper respiratory infection symptoms, no joint pains, no vomiting or diarrhea. So it is not a JIA like presentation. For JIA like presentation, the duration of illness should be longer and joint pain or arthritis should be present. It is unlikely to be a respiratory infection because there are no other respiratory symptoms like cough, coryza, etc. There is no vomiting or diarrhea, indicating direct or indirect GI involvement is not there in the patient. The parents will say high grade fever since past 7 days. Child had irritability and decreased oral intake since the onset of illness. Irritability and decreased oral intake can occur in any acute infection. It can occur in inflammation. It can occur in patients with meningitis as well. He had been treated with oral amoxiclav for 3 days with no relief. This is very important. These days, what parents sometimes do is, being a practicing pediatrician, I know half of the time when the parents come to me, they have already started the antibiotic. There is a thing called as Dr. Google available these days, and sometimes the local chemist will also give syrup augmentin or syrup amoxiclav to the patient already. So he has already taken antibiotic for 3 days without any relief. This is the second clue. So child has high grade fever for 1 week. 4-year-old is the age, less than 5 year, and amoxiclav, that is beta lactam antibiotic, has been given for 3 days with no relief. Past history is uneventful, and child is immunized for age as per national immunization schedule. Examination was done and examination revealed tachycardia. Now, tachycardia can indicate fever also. Tachycardia can indicate an irritable child also. Tachycardia can indicate shock also. Tachycardia can indicate myocarditis also. Tachycardia by itself does not mean anything. It simply means the child is either anxious or he's febrile or he's probably having some inflammation in the body. So understand that tachycardia alone is not indicative of any disease per se. There is normal hemodynamics, means there is no shock in the child. Child had no pallor, no icterus, no cyanosis. There was bilateral conjunctival congestion. This is important. Bilateral conjunctival congestion. It is pointing towards likely conjunctivitis in the patient. So there is likely conjunctivitis. There is left-sided cervical lymphadenopathy with largest lymph node size of 1.5 centimeter. Unilateral cervical lymphadenopathy, which is significant. There was mild periungual. Mild periungual means around the fingernails. Non-tender desquamation. Desquamation means peeling of skin with diffuse bilateral dorsal edema on the hands. So bilateral edema and it is day 7 of illness, so already some desquamation around the fingernails has started. There was also a rash present in the perineal region, that is around the perianal perigenital region. It was erythematous papulosquamous rash. The point to note, there is no vesicles mentioned, no bullae mentioned. So perineal rash, edema of hands and feet, and periungual around the nails, there is desquamation. So, what is the likely clinical possibility? Before I go and start writing, when you have a child presenting like this, immediately it should come into your mind what are the clinical possibilities we are thinking of. Age less than 5 years, fever for lasting 5 days or longer, no response to oral antibiotic given for minimum 48 hours. There is tachycardia, there is conjunctival congestion, no shock, unilateral lymphadenopathy, uh, changes occurring in extremities, periungual and perineal desquamation happening. So, what are the likely clinical possibilities? There is no hepatosplenomegaly and systemic examination was normal. It is not significant. So, probably thinking of, we are probably thinking of, just a minute. We are probably thinking of either some infection or some inflammation. So, what is your differential diagnosis based upon history and examination? The possibilities we will consider. The first possibility will be Kawasaki disease. Kawasaki disease. Why Kawasaki disease? Examiner can ask you in Viva or in your bedsides because the child is having age less than 5 years. There is fever lasting equal to or more than 5 days. There is no response of fever to antibiotics. Plus, the patient has conjunctivitis like presentation. So, ocular symptoms are there, ocular congestion is there. There is unilateral cervical lymphadenopathy, which is significant. There is edema of hands and feet, bilateral hands. There is periungual desquamation, which is present. And there is also rash, which is present in the perineal region. Rash can be present anywhere in these patients. Now, interesting thing to note is some people will say, sir, strawberry tongue is not mentioned. Strawberry tongue is present, but it is not always present in Kawasaki disease. Please understand that. I've seen many residents start thinking, sir, fever is there, but strawberry tongue is not there. Should we think of Kawasaki? Yes, you should think of Kawasaki because periungual desquamation and fever lasting 5 days or longer, along with ocular symptom, is sufficient to raise the suspicion. It may not be diagnostic. The diagnostic criteria says fever along with any 4 other criteria that I will be summarizing in the end. But this clinical possibility of Kawasaki will definitely be there. Second possibility you will think in such patient is scarlet fever. What is scarlet fever? Scarlet fever is a streptococcal infection. It is an infection caused by group A beta hemolytic streptococcus. That is the second possibility. But what are the points against scarlet fever? First of all, scarlet fever is a streptococcal infection. Nelson 22nd edition says the fever in this patient responds dramatically to beta-lactam antibiotics within 24 to 48 hours. Here, almost 3 days of antibiotics have been given and there is no response to fever. That is a point against. Secondly, Nelson also says that ocular congestion, that is conjunctivitis-like features, are rare in streptococcal infection, which are present in this patient. So that is why scarlet fever is a possibility, but it is not the most likely possibility. Third possibility you can think of are the viral infections. So what are the viral infections you will think of? You can think of viral infections like adenovirus infection, and you can think of measles-like infection. Both of them can have sometimes presentation like this. Both of them are mentioned as differential diagnosis. Examiner wants to hear from you when the case scenario is being discussed. Even in the theory paper, if they ask you differential diagnosis, you are supposed to mention these two. Now, why it is not adenovirus infection? Because adenovirus infection generally has purulent or exudative conjunctivitis. Plus, they will also have features of pharyngitis. Pharyngitis is virtually always present. So there will be purulent conjunctivitis, exudative pharyngitis always present in these patients. If you look at the clinical picture, they have not talked about any pus formation, any purulent discharge from the eyes. They have not mentioned any pharyngitis in the patient. And adenovirus infection will not have unilateral lymphadenopathy. If it causes lymphadenopathy, it will be bilateral. Can it have? It can have, but it will not be significant and it will be bilateral lymphadenopathy. What about measles? It is a immunized child. So measles will generally have Koplik spots present. Measles will have a typical rash. It will not have periangular rash. It will have a non-itchy papillosquamous rash appearing on the face, then going to the trunk, and there will be it will be an unvaccinated child. Here, it is a vaccinated child which is being talked about. So these are the two reasons why the possibility of adenovirus and measles infection is less in this patient. What are the other differential diagnoses you can think of? The other differential diagnosis you can definitely think of is rickettsial infection. Rickettsial infection can have presentation like this, but rickettsial infection will likely have petechia present. And these patients have hepatosplenomegaly present, which are not in this patient, not seen in this patient. So that is why it is not a number one possibility. Then can it occur in patients of leptospirosis? Yes, leptospirosis patient can also have presentation like this. In fact, Nelson attaches a lot of importance to leptospirosis as one of the differential diagnoses. But leptospirosis tends to occur in areas with rainy season. It is associated with areas with water, logging of the areas. It is associated with rats. It is associated with rice fields. None of the epidemiological features are there. And leptospirosis will have hepatic and renal failure. Hepatic or renal failure. None of them are mentioned in the question. And so you will not think of leptospirosis as a first or second or third possibility. Second last point, it can occur sometimes in systemic onset GIA. Systemic onset GIA, also written as SGIA. But SGIA will have joint involvement. There is no joint involvement present in the patient. Lastly, there can be drug involvement or drug rash, but drug has been taken after the onset of fever. So drug rash will have for some minor illness, rash was started, then fever happened, then rash appeared and it progressed. So drug rash, including Steven-Johnson syndrome, again, they will not have these kind of unilateral cervical lymphadenopathy. They will not have bilateral congestion, and the fever will the pattern of the fever, the pattern of the rash will change after the drug has been initiated. So these are the important differential diagnosis that you need to remember from theoretical perspective and practical perspective when a patient with similar findings comes to you. Now you have seen the differential diagnosis based upon history and examination. Let us focus on investigation. Now the patient case is continuing. You will ask the patient, what were the investigations? Have you got an investigation done? Sometimes, in fact, most of the times, well-off patients have already got themselves evaluated or got a private lab test report done. This is very common these days. So they will show the CBC count, LFT, RFT electrolytes to you. So when you look at the investigation in this patient, you found, right? You found that HB was 8.9 gram per deciliter. That is, it was showing anemia in the patient. Not very severe anemia. Anemia is there. TLC is on the higher side, 12,000. So leukocytosis is there with 60% neutrophils. Platelet count is 5.5 lakh per cubic mm. Can you see thrombocytosis present in the patient? And ESR and CRP are high. So this patient is having anemia. He is having leukocytosis. He is having thrombocytosis. And he is having raised ESR and raised CRP. This is going more and more in favor of Kawasaki disease. The patient is presenting after 7 days fever. So disease has started with 7-day fever already. Nelson says, there is a statement given in Nelson. You can look at Nelson 22nd edition. It says, by the end of first week, I repeat, by the end of first week of illness, if there is no thrombocytosis, normal ESR and normal CRP, Kawasaki is virtually ruled out. You understand? So ESR CRP will be high, platelet count will be high in most of the patient with active inflammation in Kawasaki disease. They are not diagnostic, but they are clues. Their absence goes against in favor of Kawasaki disease. Then LFT was done. LFT में serum bilirubin was 0.9. AST and ALT is elevated. Yes, they are mildly elevated. The normal value should be less than 50. So they are mildly elevated. So mild transaminitis is there. Nelson says mild transaminitis can occur in Kawasaki disease, and mild transaminitis will not be seen in your ricket cell infection like scrub typhus and Rocky Mountain spotted fever. You will have significant transaminitis over there. Alkaline phosphatase is slightly on the higher side, but for a 4-year-old child, his growing age, so alkaline phosphatase will always be on the high normal range. Serum albumin, there is no hypoalbuminemia and nothing else is mentioned. And RFT was within normal limits in the patient. No other investigation was done apart from ASO and anti-DNSB. They were not elevated, which is against the diagnosis of streptococcal infection. So it is not likely to be streptococcal infection. So even if your strawberry tongue is not mentioned, your most likely possibility in this child is Kawasaki disease. Kawasaki disease is the first possibility. In Kawasaki disease, it is always a child age less than 5 years who's having fever lasting 5 days or longer, which is unresponsive to antibiotics, high grade fever coming daily, along with any 4 out of 5 features. What are these 5 features we think of? The patient will have conjunctivitis. It should be bilateral non-purulent conjunctivitis. Bilateral non-purulent conjunctivitis. Your patient will have a rash. It will be a non-vesicular rash. There should be no vesicles, no bullae present in the patient. Rash can occur anywhere on the body. It can occur in the perineal region, but it can occur on the trunk as well. Then there will be edema of hands and feet. Edema of hands and feet. And this edema can progress to periungual desquamation. Remember, periungual desquamation is not present at the beginning. It always appears at the end of first week. So generally second week onwards, you will have more significant periungual desquamation. So 3-day history, 4-day history, do not think of fever, do not think of periungual desquamation in the patient. Do not look for, you look for it, but that is not a significant feature there. Then you will think of unilateral cervical lymphadenopathy with size more than 1.5 centimeter at least. On one side of lymph nodes of the neck, they will be enlarged. And you will think of mucosal changes, oral mucosal changes. Oral mucosa, including the lips, they are cracked, they are bleeding. And example, sometimes tongue is involved. Tongue is inflamed, pink red in color, swollen, has hypertrophic papillae on the surface, giving a strawberry-like appearance. So strawberry tongue can be seen. Remember, strawberry tongue can occur in scarlet fever. It can occur in Kawasaki disease. So these are the features. So fever along with any 4 out of these 5, if they are present in a patient and similar differentials are ruled out, you will think of Kawasaki disease. These features need not be present simultaneously. They can come one after the other. If only 2 or 3 features are present, but the other feature is not present, you call it as incomplete Kawasaki disease. In these patients, risk of cardiac complication is high. So you have to do 2 things. You have to admit the patient. You have to plan echocardiography to look for myocarditis and cardiac aneurysm. And you have to plan therapy in the patient. So what is the therapy that you are going to plan? In a patient of Kawasaki disease, the drug of choice will be IVIG, intravenous immunoglobulin in a dose of 2 gram per kg. It is given as infusion. The infusion should be given over, it should be given as infusion over 8 to 12 hours. So IVIG is given. Along with that, you start the patient on oral aspirin. Aspirin is always given in a high dose. Depending upon the recommendation that you are following, it can vary between 50 to 100 mg per kg per day. Let me tell you, some organizations give 50 to 70 mg per kg per day. Some give between 80 to 120 also. So I'm taking a median value, 50 to 100 mg per kg per day in 4 divided doses it is given. It is high dose aspirin which is given as anti-inflammatory response. After giving aspirin, so only single dose IVIG is good enough. And generally, most patients become febrile within 24 hours of completing the infusion. And oral aspirin is initially given high dose for 2 to 6 weeks. Then an echocardiography is planned at 6 to 8 weeks. If normal, if normal, you can consider tapering the aspirin dose and stopping it. Lifelong aspirin is not given. What is the protocol of giving aspirin? This is something we need to understand. So I'm giving the heading aspirin in Kawasaki disease. Whenever you have to give aspirin in Kawasaki disease, in first 2 to 3 weeks, you always start the patient on high dose aspirin. Why? Because it is anti-inflammatory. High dose aspirin is anti-inflammatory in nature. Once fever comes down and ESR and CRP, they become normal, you can shift the patient to low dose aspirin. What is low dose aspirin? It is 3 to 5 milligram per kg body weight per day, because low dose aspirin is antiplatelet, antithrombotic. It's a very useful concept you need to understand. In the first 2 to 3 weeks, we are giving high dose aspirin to suppress the inflammation. After inflammation has been suppressed, once fever and ESR CRP are normal, you shift to low dose aspirin. Low dose aspirin is antiplatelet, antithrombotic, so that if any aneurysm has formed in the patient, you can have, absence of thrombus formation. MI should not happen. For that prophylactic role, we give low dose aspirin. This low dose aspirin is continued till echocardiography, which is done at 6 to 8 weeks of age. If the echo becomes normal at 6 to 8 weeks of age, at 6 to 8 weeks of age, not 6 weeks of age, at 6 to 8 weeks of uh, disease duration, 6 to 8 weeks after the disease started. So if the echo becomes normal, you will taper and stop the aspirin. But if echo is abnormal, any abnormality is persisting, you will continue aspirin. If you have to change aspirin, you will consider other agents like clopidogrel and low molecular weight heparin will be considered in the patient. Again, that will become a hardcore theoretical discussion part. So that is something that we are not going to go into. The aim of this discussion is not that. Lastly, it is important for me to highlight, just because you read Kawasaki does not mean every patient is Kawasaki. Kawasaki disease should be distinguished from other conditions, but still in our country, a lot of patients are scarlet fever or atypical viral infections which can mimic Kawasaki disease. So you should have a high degree of suspicion for Kawasaki, and wherever you are suspecting Kawasaki, it is not given in Nelson, but I am telling from Indian perspective, do not try to treat the patient in your small OPD clinical setting. Kawasaki disease is like a time bomb. Any cardiac complication can happen suddenly in an apparently normal child. Always identify, and if there is any doubt of Kawasaki versus Scarlet also, immediately refer the patient to higher center. I practice in Chandigarh. I have seen some suspected Kawasaki disease patients. I make sure that of course, treatment I can do at my place also, but running a small OPD versus referring the child, the answer should always be refer the child. I refer the child to PGI Chandigarh, calling up my colleagues over there or my juniors or my friends over there that yes, suspected Kawasaki disease is coming, please take care. Because the faster you give IVIG, the earlier you manage the complication, the better is the prognosis in the patient. I hope after listening to this lecture, my advice to you, after listening to this discussion, please open your Nelson 22nd edition, go through the diagnosis part, complications part, investigation part, and the differential diagnosis part. Remaining things you will always know. You remember remaining things you will read anyways for your theory exams also. You will have complete, grasp over the differential diagnosis and mimics of Kawasaki disease. It is going to be useful for your clinics as well. Right? So thank you so much for listening to it. I hope this will benefit all of you. Thank you.